Hello everyone and welcome. This is the first discussion of a small series we're doing for Dr. Seyfried's official YouTube channel, where we're aiming to get Dr. Seyfried discussing his research with other researchers in the field. And today we have Dr. Dominic D'Agostino here as a guest with Dr. Thomas Seyfried to discuss their research together. My name is Morgan, and I'm a student of Dr. Seyfried's. I've been following his research and his colleagues' research for about 3 years now, and I'm here to help the Seyfried Lab get the message out to the public through YouTube and Instagram. And so I'll give just a brief disclaimer as well that this discussion isn't meant as medical advice, but rather a discussion of the science. And I'd like to introduce our guest, Dr. Dominic D'Agostino, first. He is a researcher and a professor at the University of South Florida, and the D'Agostino Lab conducts research to understand the efficacy and mechanisms of ketone metabolic therapies on various diseases, primarily cancer, which we'll be discussing today. And as you all know, Dr. Seyfried is a professor of biology and a researcher at Boston College whose lab examines metabolic therapies such as calorie restriction, fasting, and the keto diet, and the mechanisms by which these help manage chronic diseases such as cancer. And so welcome to you both.
Great to be here. Thank you, Morgan.
Yeah, thank you very much, Morgan. It's very nice that you're arranging this.
Thank you. So I'd like to begin with the first question, which is when and how did you both start to collaborate on research?
I could start out. So I was actually familiar with Dr. Seyfried's research on seizures, and I think I have been studying central nervous system oxygen toxicity seizures for a little over 20 years, funded by the Office of Navy Research. So oxygen toxicity seizures occur with really high levels of oxygen, and it's a limitation of hyperbaric oxygen therapy. So the guidelines sort of are capped at 3 atmospheres because of the potential for tonic-clonic seizures that happen when you go above 3 atmospheres of oxygen. And it's also a limitation for our special operations community that use a closed circuit rebreather, the Navy SEALs. So being funded by the Navy, they wanted to understand the cellular and molecular correlates of CNS oxygen toxicity. And I started that research in 2004, and anti-seizure drugs really don't provide a whole lot of efficacy for preventing these seizures, only when you use dosages that basically put someone into a sedated coma almost. You have to use really high dosages to block these very powerful seizures. I went through a nutrition course in undergrad, but didn't really, the ketogenic diet was not talked about, but I stumbled across the Charlie Foundation, which was really the only website that came up, at that time, and saw ketogenic diets could prevent seizures. And then I stumbled upon Dr. Seyfried's work in 2007, I believe. And a year after that, he had published an article on cancer studies looking at calorie restriction and a restricted ketogenic diet and cancer. And then I became increasingly interested in that and I could talk about it later, we observed a number of different cells, in high pressure oxygen, and we curiously observed these cancer cells were generating significantly more oxidative stress or superoxide anion, and we had different dyes for that, and they were dying at a level of oxygen that was relatively non-toxic to healthy cells, and I did not understand why. And then I talked to a number of different people, and then a couple years later, I talked to Dr. Seyfried, and his theory that he was advancing was really explaining what I was observing under atomic force microscopy and laser scanning confocal microscopy when I was looking at the mitochondria. So then, and that from that kind of spearheaded or launched our discussions and then ultimately our collaborations.
Yeah, and I can attest to that because I think we had an opportunity to meet at a couple of the meetings that were run by the Charlie Foundation. There was one in particular in Liverpool, England, when Dom was first starting to get these observations together, and then we started to collaborate with the possibility of gaining a better understanding of the molecular mechanisms by which oxygen stress might be a non-toxic therapeutic strategy for managing certain types of cancers. And then it became more and more clear to us that radiation would kill cancer cells by creating oxidative stress, but in a non-specific way, by creating reactive oxygen species as a kind of bombs in the microenvironment. And if a cancer cell happened to be near that, it would be blown up. But with high pressure oxygen therapy, hyperbaric oxygen therapy, it seemed to be more selective for killing the cancer cells. As Don mentioned, the normal cells seem to be more resistant to this. And we know that the cancer cell having insufficient oxidative phosphorylation by nature produces more ROS. Um, the problem, of course, is that their utilization of glucose and glutamine are metabolized to high levels of antioxidant protection through glutathione and superoxide dismutase and things like this. But we thought then if we would lower the glucose and the glutamine, that would be their metabolites like glutamate from glutamine and through the pentose pathway from glucose carbons. If we could lower the two fuels and then expose organisms, mice that would have cancer to this higher pressure oxygen utilization, it might be more selective for killing the tumor cells. And we were beginning to see this with Dr. Poff, who worked with and we were starting to see that, wow, this could be a really effective non-toxic way as potentially a substitute or together utilization with radiation therapy, because the ketones would protect the normal cells, but not the tumor cells. And the tumor cells would be made more vulnerable to oxidative stress. So together, with the late Dr. Yu and Joseph Maroon from the University of Pittsburgh, we put together a press pulse strategy where Dom and I discussed how we would take this whole cancer problem and break it down to a very manageable disorder, knowing full well that the fuels that were driving it and the vulnerabilities that we could realize once we would press down the fuels and pulse the fuels driving the dysregulated growth, and then make them super susceptible to hyperbaric oxygen and calorie restriction and things like this. And so far, it seems to be working really, really well, better in people than in mice, which has always been one of the great things that we've been able to find. And Dom and I realized that in time, press pulse therapeutic strategy will become the standard of care. The issue, of course, is it's not broadly recognized, nor are the mechanisms that Dom and I have been talking about also broadly recognized. But once they are, to me, it has all of the power to manage cancer very effectively, and also gives us the opportunities to bring in all kinds of new approaches that work together with the pressing of the glucose fuels and the pulsing of glutamine fuels together with hyperbaric oxygen, a variety of other strategies that we're now beginning to realize for the first time are effective. So the collaboration is working very, very well and is continually improving. So would you agree, Dom?
Yeah, absolutely. And I think I'd like to add too that, even before engaging in a discussion with you, Dr. Seyfried, I had talked to a number of people at the Moffitt Cancer Center and a number of cancer investigators, and they did put on my radar the Warburg effect. And they kind of said, well, there's this guy that, he's very kind of out there and advancing a theory that's a little bit controversial, but his name is, Dr. Thomas Seyfried. And then I think the article came out in 2010, Cancer is a Metabolic Disease and Nutrition and Metabolism. And it was after getting that article and just reading it over like 5 times and pulling out all the references, saying this is extremely compelling. And prior to that, we observed that high pressure oxygen causes a massive increase in superoxide in a number of different cancer models, including a GBM model, and that they die faster, and that we measure superoxide with mitosox red and dihydroethidium, so we knew it was coming like from the mitochondria, but I didn't understand why at the time. And I was also looking at something like 2-deoxyglucose and different glycolytic inhibitors, which can also be used for the anti-seizure effect. And noticed that we were trying to grow these different model cells, and it was easier to work with these immortalized cell lines, these cancer cell lines, and just it was causing, reducing their growth and increasing their cell death. And so essentially we observed that blocking glycolysis, reducing glucose, or using a glycolytic inhibitor, significantly impacted these cancer cell growth and increased cell death. And oxygen was toxic to the cancer cells. And then what was really interesting is that we kept glucose at the same level. And when we added ketones, we saw an increase in cancer cell death with ketones, and it also suppressed their proliferation. And we used the D and the L enantiomer of that. So, and that's kind of another story we can get into because I'm very interested in that. So the observation that ketones had an anti-cancer effect, that reducing glycolysis had an anti-cancer effect, and that hyperbaric oxygen had a cancer-killing effect. So we saw the opportunity to sort of combine these things in a synergistic way that could be non-toxic. And that essentially became the PhD dissertation project of Dr. Angela Poff, who came into my lab with a high interest in cancer, but I had not been studying it. I had a little bit of startup fund, so that kind of kicked off, some studies. And then ultimately, I had requested, Tom, I don't even remember that, but I wanted to do very specifically a brain cancer model. And then you talked me into the VM-M3 model of metastatic cancer. And I was like, well, I really want the brain cancer model. It's like, no, you have to work with this model of metastatic cancer. And I remember it kind of made the front page of International Journal of Cancer or something like that. And I remember reading that and I was like, okay, this is a good direction to kind of go into. And then I think it was about 2010, we actually kicked off with experiments using your models.
Yeah, well, I think the VM-M3 model is a brain cancer model.
Yeah.
But it also metastasized outside of the brain.
Yeah, so good point. Yeah.
And the issue, of course, I ran into a lot of problems in trying to get NIH grant support for that model, because the reviewers said, GBM doesn't metastasize, glioblastoma doesn't metastasize outside the brain. And then I said, what do you mean? I said, I have 70 articles here that you are unaware of, showing clearly that glioblastoma does in fact can metastasize outside the brain. And they stopped doing organ transplants from patients with GBM because the recipients that were getting these organs developed metastatic cancer. So where did that come from? It came from GBM cells that had metastasized outside the brain. But for whatever reason, the field seems to be locked into these preconceived notions, and we're resistant to the idea of this concept that metastatic cells can occur in glioblastoma. As a matter of fact, the most invasive and spreading cell of the GBM is a mesenchymal neoplastic mesenchymal cell, which we think is derived from microglia. So a neoplastic microglia cell are loaded in some of these GBMs, and they have the capacity to spread into the bloodstream and spread throughout the body, but in small numbers. And a lot of GBM patients unfortunately die before they recognize cancer cells outside of the brain. So, but the issue, of course, of metastasis, which is ultimately one of the biggest challenges in cancer. How do you stop a cell from spreading through the body? Because, if you have a localized group of neoplastic cells that have not yet spread, either surgical debulking or a radiation approach could cure that kind of a condition. It's when the cells begin to spread that we have this bigger problem. And we now know that all metastatic cells have characteristics of macrophages, a mesenchymal kind of cell, dependent on glucose and glutamine for survival. So we have a pretty clear idea of how how to kill metastatic cancer cells using metabolic therapies, which are combinations of hyperbaric oxygen simultaneously targeting glucose and glutamine. Unfortunately, the field doesn't recognize that. And one of the great tragedies in my mind is that the approach to try to stop metastatic cancer, um, about almost 50% of the people treated are killed from the treatments rather than the cancer, which is another tragedy. When we clearly know, based on work of Dom's and our work together, that these metastatic cells are remarkably dependent on glucose and glutamine, and they can't metabolize ketone bodies or fatty acids effectively, and now become extremely vulnerable to hyperbaric oxygen if you can put the patient in nutritional ketosis. And then again, with low doses of glutamine targeting drugs and glucose targeting drugs like 2-deoxyglucose, we can annihilate these tumor cells and keep the normal body super healthy. And this is one of the great important issues in cancer: is how do you selectively kill spreading tumors while enhancing the health and vitality of the normal cells in the body? And Dom and I have worked out a lot of this. It's just the challenge of trying to convince people that this is the way it is has been harder than actually knowing how to kill cancer cells. It's just the field is resistant to it more than the field is more resistant than the tumor cells. Can you believe this?
I think too, what the idea that Dr. Seyfried was advancing, like when I first read Cancer as a Metabolic Disease, I really appreciated it from the perspective of being a physiologist. So I was trained as a neuroscientist, but also I was trained to understand the neural control of physiological regulation or autonomic regulation. So I was trained as a physiologist, but then had to take neuroscience classes too. So I appreciate and understood that when you change your metabolic physiology, you are changing the fuel that you're running on. So you are dramatically enhancing and upregulating fat metabolism and ketone metabolism, and really suppressing the hormone insulin. So it's more than just ketones and glucose and ketones and hyperbaric oxygen. So I also think of, a well-formulated ketogenic diet or ketone metabolic therapy, which includes ketone supplementation that does not increase insulin. I think about it as insulin suppression therapy. And that by suppressing the hormone insulin, you're suppressing glycolysis, you're limiting glucose availability to the tumor, you're elevating ketones, a fuel that the cancer cells can't use effectively for energy. And then in that context, cancer cells have dramatically upregulated oxidative stress, and you're simultaneously inhibiting some of the endogenous antioxidant mechanisms. Mm-hmm. So the cancer cells are selectively vulnerable to oxidative stress. And we know the efficacy of radiation therapy is proportional to the partial pressure of oxygen of the tumor. And we know that hyperbaric oxygen reverses tumor hypoxia, and it also sort of decreases the lactate in the microenvironment. And that acidified microenvironment really makes the tumor resistant to standard of care therapies. So, I mean, at the time, before reaching out to Dr. Seyfried, the Moffitt was kind of interested in this idea of enhancing their therapies with hyperbaric oxygen because of the radiation therapy and things like that. And now the interest too is enhancing hyperoxygenation, enhances T cell metabolism and infiltration, and also reduces PDL1 expression, and enhances also checkpoint inhibitor therapy. So right now, the Moffitt actually has a ketogenic diet trial on CAR T therapy. So there has been an interest, and I think it was mostly spearheaded by Dr. Seyfried because of the work he's putting out, and other people now looking at ketogenic therapies to enhance the adaptive immune system to work to make, standard of care therapies that are emerging work better. And that's super, I'm interested in that area too, but I'm mostly interested in developing a comprehensive, non-toxic, metabolic-based, oxidative stress-based therapy for these cancers. And I think that's I feel like I'm working in kind of two different fields where I'm sort of, embracing the idea of using this as standard of care, and I know Dr. Seyfried has some thoughts on that. But at the same time, I think my passion is really to work with a team to advance the use, the development and the application, moving the science to human application of non-toxic metabolic / oxidative stress therapies.
Yeah, that's really good. Getting back to what you raised there, which was the acidification of the microenvironment preventing many standards of care from working, which includes radiation, chemotherapy, as well as the checkpoint inhibitors and potentially CAR T immunotherapy. All of these approaches have been recognized to be less effective or poorly effective because of the acidification of the cancer microenvironment. And the acidification is primarily coming from the waste products of the fermentation metabolism that is driving the dysregulated cell growth, and that being lactic acid. And what we have shown, and what we've shown is succinic acid. Succinic acid is the end waste product of the glutaminolysis pathway. The tumors need. We have now provided the strongest evidence that the amino acid glutamine is actually fermented in the mitochondria of the tumor, and then succinic acid, the end product of the glutaminolysis pathway, is dumped out along with lactic acid. So, and glutamate is another excitatory amino acid that's also dumped out. It's vented out from glutamine. So this is creating an acidic microenvironment. The waste products of the fermentation driving the dysregulated growth creates the acidification. So if you simultaneously restrict glucose through nutritional ketosis, and then you use glutamine targeting drugs pulsed rather than pressed, because the immune system uses the same fuel, glutamine. So it becomes essential to understand how the immune system and the tumor systems are both using a common fuel, and we have to then do a strategy to maintain the health of the immune system while slowly degrading the tumors, and removing the acidification of the microenvironment, allowing some of these other therapies to come in at much lower dosages, which make, once the tumor cells are restricted of their fermentable fuels and the microenvironment becomes less acidified, you don't need much radiation. You need very little immune therapies. You need very little of this, because the tumor cells now become super vulnerable to the lowest doses. So overall, it's a win-win situation for the patient in many different ways, and for the attending physicians, because you'll be able to manage these cancers so much more effectively. This is not being currently done. We're giving patients high doses of immune therapies and toxic chemo and all this other stuff, trying to break through the acidification when we clearly know how to stop the acidification. And so this will move. So eventually you'll have a hybrid system where the cancer cells, the patient, is placed into a state of nutritional ketosis. One of the hangups about the field is the term diet. Ketogenic diet. Ketogenic diet is very ambiguous. What's more important is the state of nutritional ketosis, which can be enhanced by ketone supplementations and various nutritional strategies that will bring lower glucose and elevated ketones. And this can be done with pescatarian diets, carnivore diets, all kinds of diets. And it could be strategized per person as very specialized for gender differences, cultural differences, religious differences. As long as the patient can get into a low glucose ketone index, which is what we've defined as being in nutritional ketosis, having a low GKI 5 or below to kill cancer cells, you need to go a little bit further below that. And then you come in. You reduce the acidification. You can come in with oxygen. Oh, oxygen, beautiful oxygen therapy works so much better on the patients. And then you can strategize which immunotherapy, which member of the standard of care can then be brought in to finish off surviving tumor cells. Because the ones that survive the metabolic therapy will all have something in common. having survived this. Therefore, an epitope on the surface of these cells could make these cells remarkably vulnerable to another strategy. So we all, as I've said many times in these podcasts, we already have all of the tools in the tool chest to effectively manage cancer with minimal to no toxicity. It's just that we're not using the tools appropriately, the ones that we have. We have to redesign how we treat patients from the very beginning and how we transition them from one stage to the next, bringing in all of the different tools that we have, which is hyperbaric oxygen, which is ketone supplementation, which is simultaneous targeting of glucose and glutamine, and then monitor the patient as how they're going through the system. Many of these people start getting super healthy. Many of these people that had diabetes and high blood pressure and hypertension, along with cancer, all of those other things start to disappear along with the tumors. And as we said in the press pulse strategy that Dom and I wrote, we take patients from a very diseased state, and then we gradually move them into a managed state. And with further improvements in dosage, timing, and scheduling, we could potentially bring them into the resolution state. And this is the goal of Press Pulse therapeutic strategy, taking all of the tools that we have developed and knowing the mechanisms by which they work and bringing them all together in a synergistic interaction to allow these patients to survive much longer with a higher quality of life.
Yeah, and it's important to appreciate its many mechanisms kind of working in synergy too. And with nutritional ketosis or ketone metabolic therapy, I mean, that could be implemented with a calorie restricted ketogenic diet if the patient's underweight, eukcaloric diet. If they're overweight, you could do significant calorie restriction. You could do therapeutic fasting to set them off and to quickly get them into ketosis. And then we have focused a lot of attention and work on developing ketone supplementation that is remarkably effective at lowering the glucose ketone index. And I think there's different types of ketone formulations that have a greater anti-cancer effect, that some of the esters will increase insulin. So you want to develop something like a buffered electrolyte DL, beta hydroxybutyrate, that is more effective. It has no effect on insulin, but has some anti-cancer effects to that. There has been quite a bit of pushback on ketogenic diets, primarily because of the high fat content of the diet. But if it's calorie restricted, or even eukcaloric, there's basically every I like to say cardio, immuno, neuro, metabolic biomarker, because what's healthy for the heart is healthy for the brain and also enhances the immune system in ways that has an anti-cancer effect. Every cardiometabolic, biomarker is going to improve. There's one biomarker that mainstream medicine has a myopic focus on, even a manic focus on, and that's LDL cholesterol, primarily because we don't have to go too much into it. We have drugs that lower LDL cholesterol and ApoB. So there's some doctors will push back on the high elevation in some patients, of the LDL cholesterol. I've consistently seen in cancer patients that LDL drops as their cancer progresses. And I think there's reasons kind of for that, but like low LDL is associated with faster cancer progression. So maybe there's an opportunity to use statins too, because, cholesterol is used for the biosynthesis of tumors. But I think the pushback on ketogenic diets is not really founded in, good understanding of metabolic physiology. And, I think it does more harm than good, especially in the context of like a GBM patient. So if they're getting pushback from their doctor on that, and we just have such good data that these diets, in the context of standard of care being completely ineffective or refractory, in the context of ketone metabolic therapy and other things that we're talking about, we could make those therapies dramatically effective and reduce the side effect and reduce the dosages. So I do think about this as an adjuvant in that setting, but ultimately I think the future is coming up with a comprehensive metabolic based approach that could ultimately replace the standard of care. which is archaic. Not that, I mean, there's some immune-based therapies that work great for multiple myeloma, lymphoma, and other types of cancers, and I think they are life-saving, and I know quite a few people. But for advanced metastatic cancer, brain tumors, and a number of cancers that I think a metabolic-based approach should be embraced and utilized in a way, and then the standard of care approaches that are being used now could be used later if they need to be, after monitoring the patient. I think that's if we're talking about quality of life and really ultimately the patient's survival.
Yeah. Well, Dom, I think you're right. Getting back to the cholesterol and these kinds of things, those problems happen when the therapeutic ketosis strategy is not done correctly. We always emphasize calorie restriction. No one should go out and eat a tub of lard thinking that that's going to help their situation. But there's so much misinformation in the diet world from ketogenic diets are so unhealthy because they're full of fat. But you can do a calorie restricted carnivore diet. You can do a calorie restricted pescatarian or even a Mediterranean diet, as long as it's as restricted and blood glucose goes down and ketones go up, measured by the glucose ketone index calculator. And when you're on the right path, a good blood marker in my mind is triglycerides. What we see when you're in ketosis, nutritional ketosis, your triglycerides are down, and which is one of the key biomarkers for cardiovascular health. You keep your triglycerides down. I'm not as concerned about the cholesterol issue as I am about the triglyceride issues. And if your triglycerides are dropping, your blood sugar is going down, your insulin levels are going down, your ketones are going up, you generally enter into the state of nutritional ketosis, which is exactly pretty much the same as all of our ancestors. During the Paleolithic period of our existence as a species, we were all in a state of nutritional ketosis because we didn't have, as Bud Veach used to say, we didn't have delicatessens or donut shops on every corner. So our ancestors were always in some state of nutritional. They had a lot of exercise, very few carbs, a lot of meat. They were generally devoid of the chronic diseases that are crippling the world population today. And we know this pretty much because if we look at tribes like Albert Schweitzer had done, looking at how ancient tribes that followed their traditional ways, a lot of the chronic diseases that are plaguing us today were not even known or seen in many of these tribes. So they were living in a state of nutritional ketosis, a lot of exercise, a lot of natural organic foods, all organic as a matter of fact. And they did not have chronic diseases. Yes, our ancestors did not have. They died predominantly from injuries and infections, mainly because we didn't have antibiotics, we didn't have orthopedic surgeons, and we didn't have a lot of the things that we have today. But they were not dying from chronic disease. Today we are riddled with all kinds of chronic diseases, cancer being the number one in that regard. And we are just trying to use our understanding of metabolic therapies to bring the body back to the way it should be, a state of nutritional ketosis, and in managing a very aggressive disease that we think can be managed more effectively. And yes, it will be the combined synergies of all of the different tools that we have. And I agree with that. But again, there's so much misinformation about ketogenic diets being harmful, and none of these are done the right way. If you do it the right way, it's almost always very therapeutic. And when you see arguments that say, "Oh, these patients didn't do well," they never were into a low GKI in the first place. They had other issues that were standing in the way. They weren't They were eating ad libitum or unrestricted amounts of fats and things like this, which are very unhealthy. So we need good nutritionists and dietitians who also understand the concepts of what Dom and I are talking about, so they can guide their patients through the strategies, through the requirements of what they'll need to do to bring themselves back to what we call metabolic homeostasis. And this is an extremely important concept, metabolic homeostasis. When you have chronic diseases, your body is not in homeostasis. You're out of balance. You're metabolically out of balance. what nutritional therapeutic ketosis does is bring you back into a state of metabolic homeostasis where cancer cells and other issues associated with chronic diseases become less and less problematic and eventually will disappear. We can cure type 2 diabetes with metabolic therapies. You can get rid of hypertension. A lot of neuropsychiatric problems that are afflicting people can be managed with nutritional ketosis. So, and we're using the GKI as simply a quantitative biomarker to allow people to know what does it mean to be in nutritional ketosis? What do I have to do? How do I know I'm there? Well, you have a glucose ketone index marker that we are developing as a tool to allow people to know what stage they're in. And then whatever disease you might have, whether it's cardiovascular disease or cancer or one of these others, even dementia, most dementias are the result of metabolic inhomeostasis, bad diets and lifestyles that are putting pressure on. And all of it eventually comes down to mitochondrial health. That's ultimately what we're dealing with here. Mitochondrial dysfunction is the underlying pathological process of all of these different chronic diseases, including cancer. Cancer is a mitochondrial metabolic disorder. Otto Warburg was the first to define cancer as a metabolic disease. The field went off the track thinking that it was a genetic disorder. We have now accumulated enough information to show that cancer cannot be a genetic disease. It's a mitochondrial metabolic disease. So we must view it as that and then develop strategies and approaches knowing that. And the outcomes on patients' overall health, the reduction of chronic diseases in the country and throughout the world will happen once people come to realize what Dom and I are talking about here.
Mhm. And I just want to add, I think there's four things that you really need to pay attention to when a patient transitions to ketone metabolic therapy. And I think there's biomarkers, and that's a whole discussion. I've given talks on that, but just the cardiometabolic biomarkers, glucose, ketones, insulin, HSCRP, triglycerides. HSCRP is actually a better cardiovascular risk factor to monitor than LDL cholesterol. The hazard ratio, it's higher.
Okay, how do you define the HSRP?
A high sensitivity C-reactive protein.
Okay.
So yeah, high sensitivity C-reactive protein. So mine trended to be high, and now it's non-detectable or 0.1 or 0.2 since I've been in ketosis. So that has
why you're always in ketosis or almost. How is it possible that you could even have a C-reactive protein elevation?
Oh, well, that's just your normal. So I have been elevated. My C-reactive protein has been elevated 2 times. One, I lived underwater for 10 days in a NASA analog, and I came up and I was breathing, 4,000 parts per million of CO2 for a while and under a lot of stress. And another time, I came back from Southeast Asia and I had a gut bug and I had some intestinal permeability that triggers an immune response. So your immune response is good. I mean, it keeps you, HSCRP is an indicator that your immune system is activated. So you see it with, age-related chronic diseases and autoimmune diseases. But when someone goes on ketone metabolic therapy, there are biomarkers that need to be monitored. You want to ensure they're not losing strength. If they're losing strength, they're losing muscle and just their overall vitality, right? So you want to monitor. I'm a big advocate of ensuring muscle strength. They should be getting a DEXA scan over time, once a year at least, or once every, because it's easy to lose muscle if you calorie restrict too much. And subjectively, you want to make sure the patient feels good on a ketogenic diet. So they need to be coached. And we know that ketone metabolic therapy can have a tremendous impact on mental health. There's a whole field that has developed, spearheaded by the Bazooki group on metabolic psychiatry. And I think when a cancer patient is diagnosed with cancer, when they get chemotherapy and things like that, they get anxiety, they get depression, and this increases exponentially. So I think one area of research that we need to focus on is actually improving the mental health of patients that have cancer. And one effective way to do that is I don't want to call it, make it sound like a panacea, but when you're in a state of nutritional ketosis and you maintain that, it has an anxiolytic effect. It actually can decrease symptoms of major depression. Dr. Jeff Volek just published on that. It could target. It could help with bipolar, schizophrenia, and also, a wide variety of anxiety disorders. So I think this is another sort of feather in the cap for ketogenic.
Well, sure. And if you're treating your patients, initially cancer patients with nutritional ketosis up front with a press pulse therapy that we developed, the probability of them getting into a neuropsychiatric problem would be reduced in the first place because
Yes.
you'd be lowering the drugs that would be initiating these kinds of neuropsychiatric problems. So clearly, all of these aspects, we have a strategy that can mitigate many of the issues that cancer patients are dealing with. The biggest, I would say, a very large problem is getting this information into the clinics. When you talk to oncologists, they have never heard of almost anything you and I have just discussed. The discussion is not even mentioned. It's not medical students in the medical schools are not getting any information about managing chronic diseases using metabolic therapies. Yet chronic disease represents the single biggest drain of healthcare costs in the world. Everybody's yelling and screaming about healthcare budgets and all this. Most of it's for managing chronic diseases. And we have a clear plan and a strategy for managing cancer and all these different chronic diseases, but the information is either not known or misunderstood, and I think there's a massive educational mission that needs to accompany what you and I have been discussing and studying for quite some time. And I'm not sure how we do that, Dom. What are our strategies for doing that?
Well, it's true. Oncologists are not formally trained in it, but I'll say no less than 3 oncologists have reached out to me for guidance because they personally got diagnosed with cancer.
Well,
So they are from the field and they are just seeking information and they're just finding what they can find online for 3 different types of cancer. So, I think, you know, mainstream oncology and academic institutions that have cancer research programs, they're very interested in enhancing their standard of care. So I've kind of, been working in that domain. I think there's a lot of potential there, but I think to move this and advance the science into human application, we really do need federal funding, state funding, probably philanthropic support, most like, and maybe industry funding too. I'm not against industry. I think we should get funding wherever we can get it to just advance, the concepts here. And it can be very daunting and overwhelming, everything that we're talking about. But at the very least, ketone metabolic therapy is achieving and maintaining a glucose ketone index of like 1 to 2 or 1 to 4. I think. And there's a straightforward way to go about approaching that. And then there's many different add-on drugs and things that you could do in
well,
addition to that.
what do you think your GKI is today?
Oh, I just measured it. So I have a GKI, right? I got the Keto
Yeah.
Mojo right here. You can see
Yeah.
there's still blood on the strip here. So I'm testing it. I'm actually have various experimental agents here that I'm testing.
Yeah.
If you consume this, this would kill 5 people into ketoacidosis. It's a very powerful.
Well, you always had those
exogenous
kinds of things. But we had a test here in the lab
Mhm.
a couple of months ago where we were going down into to test what we needed to do on a carnivore. So when I went out, I bought some nice ribeye steaks and filet mignons with sauce béarnaise and this kind of stuff. And after 4, I started off, I was about 50, which is I think it was high 40s, 50. And then after about 5 days, I was down to a 10. I got down to a 10. But if I had taken, and one of the
10
guys in
of
the lab,
what? A 10-year GKI?
a GKI of 10,
Okay.
going from 48 to a 10. But
Yeah.
one of Dr. Duray in the lab had consumed some of your, we were all supposed to be doing our whatever we need, but he chugged some of your ketone solution and he got down down below 2. He was down like 1.5. So he kind of cheated on the group because we were all supposed to see what a carnivore diet would do. But I'll tell you another thing. If you exercise
Yeah.
when you're on these diets, You get down into these low zones really fast. The question that we have for people is how you maintain to stay in the longer you stay in those zones, the more pressure you're putting on cancer cells, and the healthier your normal cells in the body, the brain, everything is getting. So the strategy is not only getting to the zone, but also maintaining yourself in the zone. And we know that people will fall out of the zone periodically. How long does it take to get back into the zone after you go out and eat a pizza or a big donut? And then you have to bring your body back into that zone again, because we can't allow people to feel uh, terribly depressed because they're not enjoying their life, what we have in our society. So this all becomes the diet and lifestyle issue. I don't know if everybody is as disciplined as you are, but most people aren't. And you have to stay in those zones, and you have to have a strategy to allow people to enjoy a party. Well, of course, if you have a deadly cancer, you might want to. But I'm talking about for prevention of cancer, because it's hard to get cancer if your mitochondria are healthy. We have never found a person with cancer having a healthy mitochondria. They're always dysfunctional in some way, especially for oxidative phosphorylation. So prevention of cancer and chronic diseases means that you should always be monitoring your GKI, knowing you don't really have to stay so low. If you were to have cancer, you better get down into those low zones to kill the tumor cells. But this knowing right now, there's a lack of knowledge on what to do and how to do it. And you and others will define strategies to help these people remain in these zones. What level of flexibility do you have in your diet and lifestyle to pop out of the zone and get back into it in different ways? Maybe a ketone supplementation and exercise would bring you back into the zone. See, this is the cutting edge. We know what we need to do. We know how to get there, but we need to know what is the best way to maintain for whatever you're dealing with. Are you dealing with, you just want to prevent yourself from ever getting cancer or a chronic disease? Or now that you have a chronic disease or cancer, what is the best way that I can stay in the zone? What is the best way that I can feel that I'm working to resolve the problem that I have? And I'm doing the thing that's nice about nutritional ketosis is a lot of the effort falls on the shoulders of the individual. You don't have to be allowing a system that is failing in managing cancer and some of these other diseases. You now have charge of your destiny because you now understand this. But they also need instructions, and they need assistance, and they need guidance from people like yourself and others that can help these folks, because it does become a real challenge. And I think this is some of the areas that we need to focus on as well.
In regard to implementation, you need to set guardrails. So you need an accountability partner. I think that's going to be important. It's hard for one person to do ketone metabolic therapy if everybody else in the household's eating,
Right.
ultra processed food. So you could use, for example, a continuous glucose monitor, and then set the parameters that when it pops up above a certain threshold for glucose, that it gives an alarm. And we know that in research, if we have subjects wear a continuous glucose monitor, we can unambiguously monitor their adherence to a ketogenic diet because their glucose is not going to spike, right? So I think, and they're like in the fitness world, on the weekends or whatever, it's pretty common for people to just prepare all their food for the week and then set all their meals aside. So this is what I'm going to eat for the week. And I think that sort of strategy could be adopted by the cancer patient. Alternatively, there are food companies out there. Trifecta is one of them. I think I've had conversations with that. They will just send you can a la carte, you could pick low carb, you could pick keto or whatever. They'll send you a whole week of food to your house on your doorstep, and you could eat that. And I think, that could be maybe affordable for some people, but maybe not all people. But I think everybody can eat, and you could just go whatever's on your grocery list and whatever you have in your house, that's what you're going to eat. So if you're following a ketogenic diet, you have to ensure that when you go and buy food, that your food list includes foods that are, in line with a ketogenic diet meal plan, and that you have that, and
Well, as you said, As
Yeah.
you said, if you're monitoring, if you have a continuous glucose, or better yet, a continuous glucose ketone monitor, so you don't
Yes.
have to prick your finger to do a keto mojo.
Yeah.
You have these
I use
zones that
both.
you
Yeah.
said would these, what'd you call them? Uh,
Yeah. I mean, you could do just,
Warnings. You have a warning
yeah, you could do
thing.
time and range too.
Yeah,
So
time and range.
yeah, if you're,
Absolutely. This is
yeah,
exciting. So people will know when they eat something, like what you might eat, what I might eat, what Morgan may eat, may elicit a different GKI. But so each person will have to know what arrangements of foods and selections would be optimal for their particular state of ketosis. And that, as I said, that could vary, but your age, your gender, all of these things could make a difference. And everybody will have to be using themselves as a guinea pig to know at what zone of the GKI they find themselves that produces a range most efficient for their body. So this then again, it's an experiment. Right now, you see, without that knowledge, people are guessing what they are unless they do the monitor from a keto mojo or something like this. They're primarily guessing. And oh, I'm in keto. How do you know? Well, I've been eating avocados all day. Yeah. Well, what's your GKI? Well, I don't know. I never measured it. So again, once it becomes easy to measure the GKI with a variety of different approaches, I think we're going to start to shift and reduce all kinds of chronic diseases because people will know what to do and how to do it. And right now we have that gap in utilization of all this. So I'm looking. I think this is a very fruitful area. I think this is the future. We know we have a chronic. Even RFK Jr. said we have a chronic disease issue. He's not wrong about that. We do, and you and I and others, we have a strategy to manage that. And we're the ones who know. We are the ones that understand the mechanisms and how to do this. I think better than anyone else does. So because you and I have had the longest exposure to this stuff, and we've been thinking about it for a long time, and we've been designing experiments to test all this, and it's not yet perfected, but it's certainly on the right path for a deliverable solution to the chronic disease problem, including cancer, and I'm excited about it.
yeah. And 20 years ago, there was like no cancer metabolism conferences. So now you have like keynote conferences. Now you have like major cancer societies and organizations have like cancer metabolism like conferences and stuff. They approach it from maybe a different perspective from, a lot of people in cancer oncology are geneticists or molecular biologists, and maybe they don't have an appreciation for metabolic physiology. And I think that is important because you change your physiology, you change the tumor microenvironment
Oh yeah.
in a way that suppresses cancer. And at this point, we do not have a cure for cancer, but we have evidence-based research and mechanisms that we can, you know, target with ketone metabolic therapies. And we also know that, we know now that in regard to modifiable ways to prevent cancer, if you look at 12 of them, and a recent review came out maybe about a year or two ago by, do you know that cancer journal? It's like the flagship journal of the American Cancer Foundation. It's an impact factor of 500. I didn't even know that was
Really?
possible, Tom. Yeah.
Journal of the National Cancer
Yeah,
Institute?
it's their flagship journal, and it was
Oh, oh,
and
oh.
they meant actually an impact factor of 500, which I
Geez.
didn't know. I had to fact
I
check it,
didn't
and
know
it
anything
actually
like that
is.
existed. Yeah.
It's the highest impact journal. So they published an article on modifiable risk factors for cancer, and of the 12, I would say 8 or 9 of them were directly related to metabolic health, right? Like obesity, like smoking was the top, but that's going to be replaced by like obesity. It's like, high blood glucose, inflammation, like all these different things. And the ones at the bottom, maybe that were not included were some things like maybe H. pylori or different like Epstein-Barr virus and things like that. But I also think that ketone metabolic therapies can be used to augment the immune system,
Yeah.
and even change the microbiome, for example, to even target things like H. pylori, or to enhance your immune system in a way to prevent some of these viruses from having oncogenic effects like in the body. So
Yeah.
I think, adopting this way, I'm very interested in basically protocols that people could do for 5 days or maybe of a week, once every month or 3 months, that could put themselves into a state of, therapeutic ketosis for a predetermined time frame. And work by Walter Longo showed that you have lasting effects from that, 2, 3 weeks, even months,
Yeah.
if you can achieve and maintain a glucose ketone index, which would be equivalent based on his research between like 1 and 4. And you do that, 5 days out of every month or two. And I think that can actually produce long-term changes in various biomarkers that would correlate with prevention of cancer.
Yeah, well, we did some studies years ago with the mice when we fasted them. Now, a mouse with a 40% calorie restriction is like a water only fast for humans,
Mhm.
and like a 7 day water only fast for a 40% restriction. And then when we refed the animals, um, they were eating less food, but maintaining the constant body weight that they had, which means that their entire physiology has been made more efficient. Body weight is a critical variable to know how your body is overall physiological state. So these animals were eating 8% less food than they did before they had the therapeutic fasting, and yet maintaining the same body weight. So clearly the energy efficiency, they were more energy efficient in what they were doing. This could possibly explain what Longo was saying, that your
Yeah,
body has learned to become more energy efficient.
that's
The
why
problem
dieting's hard. Yeah.
yeah, 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 yeah. But the problem with that is, of course, is if you're eating a high carbohydrate meal, you're going to gain weight a lot faster after doing something like this. So, but again, these are the issues. Once you understand this, then you can develop approaches to deal with it. And right now, everything seems to be for a lot of people a mystery. They don't understand this and they don't understand that. But with respect to the drop in cancer deaths, the biggest was the anti-smoking campaigns from the 1990s, not any new development in drugs. The cancer has increased consistently. And I get a little peeved when I hear people say that, oh, we've made enormous progress in cancer. The progress was the anti-smoking campaign predominantly. None of these new drugs are having any major effect on dropping death rates. And that's because they think that cancer is a genetic disease. All of the new drugs are being developed. They're all based on the molecular biology of cancer, which is a genetic problem. And if it's a mitochondrial metabolic problem, you're never going to get a reduction in death rate. Once you realize that this is a mitochondrial metabolic problem, it explains why the anti-smoking campaign was so effective. And you can then institute and get real reductions. You can get real reductions in dropping the death rate. But a constantly approving EGFR receptor immunotherapies or all this other stuff, this is not going to make any major differences. The other thing too is I agree with you. I never use the term. I try never to use the term cure. What we're interested in is management. And I think if survivability for a particular deadly cancer like glioblastoma or pancreatic cancer or advanced lung cancer, if you can triple or quadruple the months of survival in a higher state of quality of life, I consider that success. If you can make glioblastoma a 5-year survival the norm rather than the exception, I consider that success. So you're giving people an opportunity to live on the planet with a higher quality of life, far greater than anything that's currently being done. I consider that success. So if the management runs long and you die from old age, from something other than cancer that you had when you were in your 30s or 40s, then you were cured. But we don't know because at any time, under a certain circumstance, cancer could come back again. And then you say, well, you didn't cure me. Well, the design was never to cure, it was to manage. And if the management lasts long enough, then you can say you were cured. But I think we should always look for successful management. And what does that mean? It means a high quality of life with no evidence of disease. In the case of Pablo Kelly, who lasted 10 years with a glioblastoma, it never went away. He was just managing it with metabolic therapy. He had 4 debulking surgeries and died from a cerebral hemorrhage on the last surgery. That he never died from the glioblastoma. He died from a surgical problem. So he lived 10 years, had 2 children, got married. He had married and 2 children. That's what I call success. Because had he gone standard of care, he would have been dead within a year or 12 months, like the physicians told him. So I consider him a success. I consider so many other people a success. They're living longer with a higher quality of life because they've done metabolic therapy. And you and I are perfecting this. So the managements can be pushed and pushed and pushed far into the future, which is success. And this level of success is far greater than what's currently being done with standards of care, which, as I said so many times, are so toxic, based on an incorrect theory and an incorrect or lack of understanding of the very topics that you and I have been discussing.
Mm-hmm.
Would it be all right if I jump in with a quick question?
Yeah.
Yeah, because Dom and I can go on for hours.
That's perfectly fine. You've been going through all of your research together, which is exactly what we wanted. But based on all that great summary of your past research and how really ketogenic metabolic therapy can potentially become the new standard of care for cancer, I wanted to touch upon a very common audience question that you get, Dr. Seyfried, in your comment sections, where a lot of people ask, when they've heard about the press pulse protocol and KMT for the first time, the first question they ask is, are there any clinics or potentially clinical trial groups that are providing this guidance to patients? What would you both have to comment on that?
Well, I mean, I get that all the time from thousands of people who contact me. They get all excited. They hear what Dom and I are talking about, and then they go to their major clinics, whether it's MD Anderson or Dana-Farber, Sloan Kettering, the Moffitt, maybe Fred Hutch, all of these different cancer centers. And a lot of the times the people, well, I never heard of it. What do you mean this? Glucose has nothing to do with cancer. And the patients get very disillusioned and feel very bad. Sometimes they're met with hostility. But the issue is why are there no clinics? Why are the top medical schools not entertaining what we're saying? And again, a lot of it has to do with the power of the system. The system is based on large profits. The cancer industry is a multi-billion-dollar industry, and I think I hate to say it, but it's revenue generation. How do you generate revenue to the same level as we're currently generating when you're using calorie-restricted ketogenic diets, ketone supplementation, exercise, and a lot of the things that Dom and I have been speaking about? It has not yet got into the mainstream because it would be very unsettling to a lot of programs to have people wanting that as opposed to very expensive toxic therapies. Why? I think there are small clinics opening up. We're starting a new society of metabolic oncology, International Society of Metabolic Oncology, where Dom is a participant as well as I and many others. There is a growing awareness that what we're speaking about will be very effective in managing cancer. But we need more education. We need clinics that will allow us to do that. We have to have open-minded people in the IRBs, institutional review boards, who are interested more in patients than revenue generation. And then once you start having that, you'll start to see a groundswell of interest and perfection of what we're talking about. But right now, that's one of the biggest problems, as I was telling Dom, is that these poor people, they have nowhere to go. And we're doing the best we can to try to train people. And a lot of it's being done on Zoom and small clinics, but it's not yet mainstream by any stretch of the imagination. So we need to get it out. We need to have people have this opportunity to be treated by knowledgeable physicians, people who know what Dom and I were speaking about, people who are able to integrate standards of care effectively into what we're talking about. We have some clinics opening up in Istanbul, Turkey. As a matter of fact, we were talking to a couple of folks the other day, MDs in their clinic, where many of their stage 4 pancreatic cancer patients are living beyond 5 years doing metabolic therapy. We have to publish these papers as well. We have to let the scientific medical community know what was done and how these people are living so long, what was done. So again, it's an educational mission, it's a scientific mission. But right now, that's one of the biggest problems. These poor folks have nowhere to go to get the stuff that Dom and I are talking about. So that has to change. And once it changes, then I think we're going to see a big drop in cancer and a lot of these other chronic diseases.
Yeah, I think the problem is multifactorial and kind of multidimensional in some ways. So, you know, they're going to ask, I mean, we really need systematic reviews and meta-analyses of the literature to convince people. So that's going to require, gold standard RCT therapies on these things and it's not going to be done as a standalone. It's typically going to be done to augment, but you also have a lot of heterogeneity within the field of cancer, like the different types of cancer. So, but I think it's most important to focus, as Dr. Seyfried has done, on glioblastoma, because that's kind of like the therapy that if you can make some inroads into that, then we'll have kind of a basic understanding that cancers that are highly glycolytic, that have this mitochondrial damage and that really have the hallmark characteristic or phenotype of the Warburg effect, that they're going to be responsive to metabolic therapies. And cancer institutes do not even have on staff registered dietitians that are trained in understanding ketogenic therapies unless it's for pediatric epilepsy or something like that. So there needs to be education into the power of nutrition, in cancer, in metabolic management of cancer, and there needs to be guidelines for implementing this. And oncologists need to really expand. The field of oncology needs to expand into metabolic oncology. And even exercise is a very powerful tool. The research behind exercise in oncology is remarkable. So exercise oncology. So that could be, another field. But I think of exercise also as a form of metabolic therapy. So even just a cancer patient implementing this could just do, 20 to 30-minute brisk walks each day, if they're able to do that. And that's going to have a tremendous effect. And it's just simple things that cancer patients can do. But when a cancer patient goes to a clinic, the standard of care happens to you. So with ketone metabolic therapy, what we're talking about here, the ketone metabolic therapy is implemented by the patient in their home, ideally under the guidance of a trained registered dietitian who has a background in, implementing and advising and directing patients, because every patient is a unique metabolic entity and they really need to be coached. And that's why I really emphasize, biomarkers, looking at, quantifying and measuring your body composition over time, looking at subjective things like your mental health and your energy levels. Like all these things need to be taken into consideration to get the best outcomes for cancer patients, because otherwise, if it's implemented improperly, the potential for harm can exist if there's too much restriction, if there's diets that are not well formulated, and even with some of the off-label applications or off-label drugs, they have the potential to do harm if they're not utilized in a really strategic way, in a really calculated way.
Yeah. Well, Dom, I agree. Well, I know we started with GBM glioblastoma only because they really don't have anything. There's been no advance in 100 years for managing that cancer, and we have a clear strategy for keeping these people alive a lot longer. But I'm not. I now having looked at in detail all the major cancers, We have never found a cancer with a normal number structure and function of mitochondria or having a normal sufficient oxidative phosphorylation, meaning that every major cancer will be susceptible to ketogenic metabolic therapy because every major cancer has the same pathological problem. They are dependent on a fermentation metabolism of glucose and glutamine. We have never found a cancer that can survive without glucose and glutamine. So that means lung, breast, colon, bladder. I don't see cancer. I see it as a singular disease, not as multiple disease. Heterogeneity only in the form of genetic mutations, but not in the form of a metabolic problem. They all have, all major cancers. We have looked at, I just in our new big paper on the emergence of the mitochondrial metabolic theory and the Warburg hypothesis, we have found that all major cancers have insufficiency of oxidative phosphorylation requiring a dependency on substrate level phosphorylation, which is a fermentation, meaning that all the major cancers will be susceptible to management with ketogenic metabolic therapy. We just focused on GBM because they have nothing, but they really don't have anything for advanced lung or pancreatic cancer either. But those cancers are remarkably susceptible to the same therapeutic. This is what's really important. All major cancers are a common disease of energy metabolism, and metabolic therapy targets that common pathological problem, meaning that we have a strategy for managing all major cancers. We have the scientific evidence to support what I'm saying. But I agree. I mean, we started with GBM because they're really desperate and lack of anything. But we can do the same thing for all the major cancers. Early stage cancers can be stopped dead in their tracks. Yeah, I'm excited about this, and I know it's very controversial to what the NIH says that cancer is 100 different diseases. They say it's a genetic disease on their website. I mean, this is all misinformation that needs to be corrected. And the guys down there at NIH, they better get their act together soon because the people are learning what's going on, and they better be consistent with the science. And if they're not consistent with the science, they're doing a great injustice to the American and the world population.
I have a question to follow up on that. I wanted to hear both of your opinions because you both briefly mentioned funding and the need for more funding for this kind of research. Based on both of your experience doing research in this field, is there or does there seem to be a bias in organizations like the NIH who provide grant funding for this type of research if it doesn't involve a drug or a treatment?
Well, it's not necessarily a drug or a treatment. It's the theory under which we view the disease. If cancer is considered a genetic disease and you're coming in with something that's unrelated or different from that, then you're not going to get funded. And who are the people sitting on the study sections at the NIH who award the grant? They're ultimately the people who make decisions. And if you're saying that we're studying a way to manage cancer that does not involve targeting genes or sequencing genes or doing this kind of thing, the enthusiasm is much less than if you're doing what mainstream thinks is to be done. This is why the paradigm shift has to happen. It's not a genetic disease. And people who think it is are standing in the way of progress. And the majority of the NIH, National Cancer Institute, thinks cancer is a genetic disease. So you're dealing with a very foundational resistance because the theory what we're talking about is a different kind of a theory for the disease. It's a mitochondrial metabolic disorder. It's not a genetic disorder. The evidence is so overwhelming against that theory that you have to be living in the dark ages not to see it. So that has to change. Once that changes, then there's going to be a groundswell of funding and interest in what we're talking about. But that time is not today.
The idea I just want to put out there because there's also epigenetic regulation, and the metabolic control of epigenetic regulation can be pretty profound. So these metabolites in circulation not only function as, in energy and growth and things like that, but these metabolites lactate and beta hydroxybutyrate, for example, there's a field called, a process called beta hydroxybutyrylation, where the beta hydroxybutyrate can directly interact with the histone and cause histone modifications that can activate gene programs that have an anti-cancer effect. So I think the field can embrace this idea of altering metabolic physiology with ketone metabolic therapies to actually produce an epigenetic effect. We know that ketones can function as histone deacetylase inhibitors. And there's a whole anti-cancer drug class with histone deacetylase inhibition. So I have an outlook perspective that I think the field can sort of mesh, that people on the genetics and metabolism can kind of converge on epigenetic modulation, and there could be some crosstalk to advance some of these metabolic therapies and maybe repackage them as metabolic epigenetic therapies, because there's a dynamic interaction between the metabolic control of epigenetic regulation and also immune regulation. So our gut microbiome, for example, is profoundly changed with dietary therapies and metabolic therapies. And there's various things like you can expand the CAR T therapy. You can expand T cells with and beta hydroxybutyrate plays a big role at sort of expanding the T cell. So that's why Moffitt is looking at CAR T therapy and ketone metabolic therapy. So I think I'm hopeful that the field will kind of go into the direction and think about these ketone metabolic therapies as in more advanced terms. And I think there's a lot to unpack and understand in regard to, even delving into the multi-omics, the transcriptomics, the even metabolomics, because I think these things it's kind of simple. It could be packaged in a simple way for the patient, but I think there's a lot for the scientists to unpack in how these things, and even personalizing therapies too, using some of these advanced tools that are already being used in oncology. And that could be, big NIH R01 grants, program project grants. I had an email this week from Casey DeSantis from the state level. They were specifically asking for proposals with rapid implementation that included nutritional therapies, repurposed drugs, and ivermectin. So I was like, I had to read it over like 3 times. Like they're literally asking, at least in Florida, for proposals, $2 million proposals that would include ideally nutritional-based therapies, repurposed drugs, and ivermectin. And I was just like, wow, this is sort of, maybe Florida is a little bit more innovative at the state level in asking, but they're very and it was just a 12 weeks, and it had to be something that could be rapidly implemented in patients. So hopefully the NIH can embrace that spirit of things outside of mainstream oncology.
Are you going to apply for that grant, Dom?
I'm working on that today. I
Well,
use ivermectin all the time. My blood levels of ivermectin are off the charts because we have this pour-on that you do with the cows and everything. I just rub it in. I never even wear protection, but we do it, you could do it orally, sub-Q injection, or the pour-on stuff. And I use all that.
Well, we were planning to do ivermectin studies, but it became such a hot political topic. I didn't want to get into it way back a couple of years ago. But we have a paper in bioarchives now, but it's under review for a bigger journal on embendazole, the parasite medication, knowing that embendazole targets glycolysis and glutaminolysis pathways. And when you put it under calorie restricted ketosis, it works really, really well. We haven't tested ivermectin yet, but we have that in the plan. To look at that, because it turns out that the parasites, and so many people make a mistake, they say cancer is a parasite. Cancer is not a parasite, but parasites and cancer cells use common metabolic pathways for survival. And some of these parasite medications that wipe out these parasites do an effective job in wiping out the cancer, especially when you're in nutritional ketosis. So again, repurposed drugs, but again, they're very cheap. They're not like big blockbusters that are going to make drug companies billions of dollars. That doesn't mean we can't find new glutamine targeting drugs or things like this. But we're certainly realizing that repurposing drugs again, as I said, all of the majority of what we need for managing cancer is already there. We just have to know how to use these things better. Don, 6-deoxynoreleucine, the best glutamine targeting drug that we can find. And we're learning now how to reduce its toxicity, especially under nutritional ketosis. And that's another thing. When you're in nutritional ketosis, so many of these other things work so much better. Everything works better when you're in nutritional ketosis. And all cancer patients should be in this state. Yeah, the hybrid systems are coming in. Epigenetic, mitochondria, the most powerful epigenetic system in the cell. They control the nucleus. They are the controllers of the destiny of the cell. When the nucleus needs to do something, it's usually under the direction of the mitochondria, because without energy, nothing works. So yeah, I'm enthusiastic about it, and I think there's going to be a lot of major breakthroughs coming down the pike here in a very short period of time. Hopefully, that's our hope.
Thank you very much to you both. This has been a really fruitful discussion. I think Dr. D'Agostino, if you have to jump off the call.
Yeah, I do have to jump off the call, but I want to mention that in the time that I've been in this, short interview, I've gotten about 5 messages from patients and one is from an oncologist, asking for more information about this for themselves. So this is, an emerging topic of great interest, and I think just getting more awareness out there and educating people on this will hopefully stimulate the conversation to make funding more available, and to develop resources and protocols that could be available for patients. And I think that's the most important thing.
I think you both are doing a great job in bringing this information to the public. I'm very excited to get this video out here.
Thank you,
Morgan. Very much for your time.
Thank you very much for your time as well.
Thanks for hosting, Morgan. Appreciate it.
It was a pleasure. It was my pleasure.
Open for a part 2 anytime. It's good seeing you, Tom.
Yeah, great seeing you, Dom.
I gotta jump into teaching.
Yeah, you take it easy now.
Thank you very much.